talked about sexual behaviors not having anything to do with libido. They have seen some success in men because the estrogen therapy and medroxyprogesterone therapy is specific to decreasing a man's libido, and they do use those type of therapies to try and control some of these inappropriate behaviors when first-line therapies and non-pharmacologic therapies have failed. So what we don't want to use, so we're right back again to those antipsychotics, right? You guys remember that slide a couple slides back with the warning about not using antipsychotics? So it's the exact same thing here, except in this case for inappropriate sexual behaviors, there's no antipsychotic that's recommended. So we had risperidone recommended for combative behaviors. In this case, there's no antipsychotic recommended. Why? The side effects that come along with those, you know, the juice isn't worth the squeeze, right? We don't want to risk falls. We don't want to risk injuries from falls. We don't want to risk someone just being sedated in their room all day. And again, that box warning is something to think about, especially as a provider, to be sure that you have the right reasons for starting an antipsychotic on someone with these symptoms. So some other medications that we see, and again, these are usually recommended PRN, even though it's not really quite as effective. And also in our skilled facilities, you know, what does it take? I mean, in our ALFs, can a med tech decide if someone can get a PRN medication? So, right, they can't, right? So a lot of these PRN medications that we see are ineffective or not useful depending on the care setting. So again, something to think about. Those benzodiazepines, the lorazepams and the diazepams and those kind of medications still have those fall risks. They really don't have a good efficacy, and the side effects and the dependence, because you're going to continue, even if the provider decides to schedule it daily, and it's helpful for a little while, there will become a time where that patient becomes tolerant, and you're going to have to schedule more, and then you're going to have to schedule more, and you know, it'll just be ongoing. So as we go through, you'll have some questions here in a second, which kind of talk about this, but in a nutshell, we just want to make sure that we're not using antipsychotics, we're not using the benzodiazepines, we're not using valproate, right? Valproate is in the same drug category as carbamazepine, which was also effective for combative behavior. But what they found is for the inappropriate sexual behaviors, the anti-epileptic medications are not as effective. So you're kind of limited when it comes to the inappropriate sexual behaviors as far as therapies. You're really limited to 3. And just to recap those real quick, it is the non-pharmacologic therapies, and then trying to start an SSRI and maximizing that. And then in male patients, starting hormone therapies can have some effectiveness. So your next self-assessment question, which of the following is not a typical etiology of inappropriate sexual behavior? B, that's correct. Snuck another one in on you. So, why would you avoid atypical antipsychotics in managing inappropriate sexual behavior? I heard the answer. Somebody said C. Right. Very good. So, is it always behaviors related to dementia, right? Is it always because of, you know, those cognitive declines that we see this stuff? And the answer to that is no, right? Our populations are diverse. It's not always people that are 80 and up that are in our facilities. I actually see more and more young people all the time. Alan used the example of Bruce Willis, which I think we would all consider as a younger resident, right? But I would venture to say a lot of us have those younger residents in our facilities. So they're there and they kind of seem to be increasing in volume for whatever reason. But we need to kind of look at that, right? We need to make sure that we're not focusing on something or maybe asking a provider to look at something or treat something that could be caused by something else. So having the right history is important on our folks that are in our facilities, and making sure those providers that help in our facilities have an important or an up-to-date H&P to be sure that it's not like an alcohol-related brain injury or some kind of functional cognitive decline, or even just good old, aging decline, right? Mild cognitive impairment, which again, we all know older people, even though they may not have clinical dementia, have some cognitive decline. This thing just died. Look at that. Lucky you guys. You guys hear me without it? Yeah. All right. Excellent. So, we know older people have cognitive impairment, as time goes on, usually, although I watched an interview, actually just today, with a lady that was 103.
I've cured your mom's cognitive impairment.
He threatened me with an age joke this whole time because he likes to tell everyone that I am significantly older than he is.
I guess we're gonna get
Well, see? You set me up. You'll just have to yell. Because of my age, I'm good at yelling. Right? So, in a nutshell, making sure that the provider is looking at the right thing in our residents is important. We'll leave it at that. And then just in review, when we're talking about combative behaviors, you have those first line medications, and this is after redirection, right? After our non-pharmacologic approaches, after maybe environmental changes or whatever it is that we can do to try and avoid medications. You have risperidone or citalopram. That second line therapy for combative behaviors is carbamazepine, which is that seizure medication by drug class, but it helps with combative behaviors. And try and remember, if someone does start on risperidone, to follow with the provider, make sure that you try after maybe 12 weeks or so to kind of get rid of that medication, right? You can try cutting the dose in half. You can move the dose to every other day, because maybe that stimulus, even though it wasn't identified as transient. So we want to hope that we can get them off some of these medications, even if we do end up starting them on the medication. And then for inappropriate sexual behavior, as we look at first line, that citalopram again, so the antidepressant. Second line therapy is hormonal. Remember those non-pharmacologic therapies again before we start any of these. And then the goal, obviously, is to reduce some of those inappropriate impulses. And the goal for our combative therapies is to reduce those similar combative